And I will go ahead and introduce our presenters. We have Marcy Dawson. Marcy is an RN and paramedic who did most of her career in emergency care. She has been an RN for 40 years and obtained her EMT in 1986 and paramedic in 1992. Marcy's worked both in a rural CAW and in the emergency room at both St. Alexis and Med Center 1, currently Sanford Health. Marcy has volunteered for several rural ambulances as a paramedic and has 18 years of flight nursing experience. Currently, she is a flight nurse with Sanford AirMed and an adjunct instructor with Sanford EMS Education. She is certified in flight nursing, emergency nursing, and trauma nursing. Marcy currently works with education for Bismarck Dickinson AirMed medical crews. She is also an EMS instructor coordinator and is part of the critical stress debriefing team. Marcy currently volunteers with the New Salem Ambulance. And we have Tyler Kintoft. I hope I said that right. Tyler is a career EMS professional that has over 10 years of experience working in many rural and urban EMS systems. He is currently a paramedic with the Dickinson Area Ambulance Service, as well as the lead EMS educator outreach coordinator for Sanford Health. Prior to that, he also served on the Kildare Area Ambulance Service as a paramedic and training officer. So with that being said, thank you both for being here today to present this useful information. If you want to go ahead and share your screen, we can get started.
Okay, I will get my screen shared here, and we will begin. So to start out with, I wanted to mention that in 2017, the Mission Lifeline for Stroke received a grant, and that is to help improve the stroke system of care. And they received, they're going to spend about $5.6 million to improve the stroke care, and the grant was $4.3 million from the Leona M. and Harry B. Hemsley Charitable Grant. And we talk about stroke. We've all heard of strokes. We've seen it for many years, and usually the definition is a sudden death of brain cells due to lack of oxygen caused by blockage of blood flow or a rupture to the artery of the brain. It used to be called a CVA, but don't let that fool you. It is not an accident. These are not an accident that happens. The key word in this definition is sudden. The symptoms come on suddenly. So if you have somebody that's having symptoms that's been going on for days or weeks or, slowly getting worse, this is probably not a stroke. So sudden is the word we want to, the symptoms come on suddenly. Time is really important, not only just for getting them their treatment, but also you lose brain function the longer the stroke goes on without being corrected. And they say that you lose about 1.9 million brain cells every minute during a stroke. That's a lot. So you think if you're 30 minutes or even an hour away from your care, that is a lot of brain cells that you are losing. This is about equivalent to 3.1 weeks per minute that your brain ages. And so if you think about that, this is why time is really important. So there's about 57 million brain cells that are lost every 30 minutes. There's two different types of strokes that you can have. It's either the ischemic stroke, which is a clot or a thrombus that goes in and blocks the blood flow to the brain, or else the hemorrhagic stroke, in which the vessel breaks and you get lack of oxygen to the brain. With the ischemic stroke, it can be one of two ways. It's either a blood clot or plaque that builds up and it just blocks the blockage of that blood flow to the brain. Also, people that have atrial fibrillation oftentimes will throw clots. They can get a clot that travels to the brain, or if they have a DVT, deep venous thrombosis with the blood clot in the leg. It travels to the brain and can cause the stroke at that area. 87% of all strokes are ischemic. So that's the majority of your patients. So it can be in any kind of artery or vessel that, it can occlude. And you can also have them in large vessel occlusions. And a lot of them are from large vessel occlusions, in which it takes more than just giving them the TPA. They get large symptoms. And the larger the vessel that is occluded, the more symptoms they are going to have, and the more damage to the brain that is done with that. Hemorrhagic strokes can be they break, the blood vessels break, weakened by disease like hypertension, causes a weakening of your blood vessels because of that extra pressure that's put on the vessels. It eventually weaks and it breaks and it can bleed. And you can also have like subarachnoid bleeds. The thing is that you want to know is that you cannot tell the difference between a hemorrhagic stroke and a ischemic stroke without doing some CT scans or some further tests. 13% of your patients have bleeding strokes, but you actually need to have a CT scan, sometimes even an MRI, to really rule out if you're having to differentiate between the two of them. So it can be any of your vessels that you can bleed. It can be an aneurysm, or it can just be the smaller vessels within your brain. If you have a subarachnoid hemorrhage, this is usually comes with the symptoms of having the worst headache they ever had. And what is happening, the blood that is bleeding into the brain is irritating the meninges in the brain, causing that pain. And so that may be one of your symptoms if you have a subarachnoid hemorrhage. If you have intracerebral hemorrhage, your symptoms may not be any different from your ischemic stroke. And so you do not know what type it is. So they can do large vessels for your bleed and small vessels alike. Then they have the transient ischemic attack. This is what they call the TIA. This is when you have the temporary interruption of blood supply to the brain. It causes the symptoms, but the symptoms go away. If symptoms may last up to 24 hours, but they go away without any treatments. Most of the time, they will come within minutes and go away within minutes. The clot either dissolves or it travels to another part of the body, and usually lasts less than 5 minutes. So TIA and stroke, they have the same kind of symptoms. They act just like the stroke, and they're treated the same in the pre-hospital setting. You don't treat it any different. You want to make sure that these patients get to the emergency room. Oftentimes I had a gentleman that on Easter, he had his whole family at his house. While he was eating lunch, he dropped his fork. He suddenly had drooping on his right side of his face, and they called 911. By the time we got there, which was just a few blocks away from the ambulance, his symptoms were completely gone. Of course, he had a house full of company with family. He did not want to go to the emergency room. So what do? The key is that you still want to assess them. You still want to do your blood sugars with them. And you want to convince them they need to go to the emergency room, because the chances of them having another stroke is pretty high. TIAs is a warning sign for a future stroke. It's not just a mini stroke. Think of it as an imminent stroke, that they will have a stroke soon. About 1/3 of them will go on to have a severe stroke within 1 year, and about 25% of them who suffer a TIA die within 1 year. So they need to go to the emergency room and find out what is causing this. Why did they get this? Maybe they have a new onset of atrial fibrillation, and now their heart is throwing out these clots. Maybe they had a blood clot in their leg that traveled, And so they need to go to the emergency room. So you need to be pretty insistent that they need to go there and give them the risk and benefits of why, the risks are if they don't go to the emergency room. Oftentimes, these patients need an MRI to decide whether or not if they had a stroke or not. At this time, Tyler is going to take over, and with this.
Thanks, Marcy. So yeah, I'm going to talk about stroke assessment. First and foremost, I want to let everyone know that while I'm talking, just because this is a virtual platform doesn't mean you aren't free to interrupt me. So if you have a question, don't hesitate to raise your hand on Zoom here. Don't hesitate to throw something in the chat box. Whatever works, but feel free to interrupt me. You can interrupt me while I'm talking because one, I'm married and I have 4 kids. I'm used to it. It's not a big deal. So we're going to talk about the Cincinnati Pre-Hospital Stroke Scale. This is probably one of the tools that we're most used to seeing and utilizing in the pre-hospital setting. It's old hat. It's something that we learned from the first time we opened up a stroke section in our EMT book, and we spent a lot of time with it. It's important for us to remember that doing a Cincinnati Pre-Hospital Stroke Scale gives us a 72% probability that the patient is actually having a stroke. So there's quite a bit of room, that's 28% that are missed using just the Cincinnati Pre-Hospital Stroke Scale alone. And it's important for us to understand what makes up that 28%. A lot of it comes back to our assessment and the way we're treating those patients and how we're treating those patients and the way we're assessing them. Like you, before stroke became this word that we incorporated in our daily lives as pre-hospital care providers, I, for one, thought, the only thing I can do, even as an advanced care provider, was start an IV and treat with large boluses of diesel, right? So we hit the gas and we drive fast to get them to a facility and let them take over from there. But the reality is that our assessment using different types of tools is what's really going to guide this patient's care throughout the entire system from start to finish. The things that we do and the things that we assess, the things that we note and we document on scene are actually going to help dictate the care that we provide long term. Just remember that any part of the Cincinnati Pre-Hospital Stroke Scale is positive during that initial assessment. We need to realize that that's a load and go patient at that point. So further assessment and treatment can wait unless it's airway, breathing, or circulation. So if there's a complication with the airway or breathing or circulation, obviously we would intervene and correct those problems immediately. But if they're breathing fine, the airway is patent, and their circulation is not compromised other than the stroke, we would load that patient and we would want to start our way to the hospital. We do not want to delay transport after we have any positive sign or symptom of that Cincinnati Pre-Hospital Stroke Scale. When we look at the statistics, there are a lot of different things that we think about. What are the types of patients that we're missing? Are these patients the ones that we most commonly write off? These are our standard patients that we see day to day, the ones that we see the most, right? How many times do we get called out for a sick person not feeling well? How many times do we get called for someone who's just feeling weak? How many times do we get called for someone that's intoxicated on alcohol or some other drug? These are the types of calls that we see the most frequently. And these are the patients that we actually miss most frequently when we talk about stroke because they mimic so many other different things. So as we're reviewing those 736 stroke patients, 14.1% did not have any fast symptoms on presentation. 42% of those had gait imbalance or leg weakness. 40% had visual symptoms and 70% either symptom. Think about those signs and symptoms that were missed. And think about the things that I kind of just talked about and other common frequent calls that you get. When they are having, sick, they're weak, they're intoxicated, they're going to have gait problems, they're going to have imbalance or leg weakness, they're going to have all those things. So it's important for us to do a really, really good assessment and use some of our stroke identification tools that we're going to talk about here in a little bit to be able to sort some of these things out and determine whether a stroke code should be called or whether we shouldn't. It's really time to alter our thinking and rule out stroke on all types of patients and field impressions. So be prepared to kind of make changes to the way we handle things. North Dakota Stroke Task Force was formed, and they recommended 2 tools. The first is the Be Fast Stroke Assessment Tool. When we look at it, once we get past B and E, it looks very similar to the Cincinnati Pre-Hospital Stroke Scale and how we use that assessment. But we add balance and we add eyes. This will help identify strokes in the posterior part of the brain that can otherwise be missed. So when we look at balance, balance and eyes, we're going to have sudden trouble walking and dizziness, loss of balance and coordination. So what are some of the things that we can do and how can we test? And so the pictures are the best way we can do this right now. And of course, I'm going to get a little animated on screen, so I apologize ahead of time. First of all, we talk about coordination and how we do some of those tests. You can see here that this gentleman is taking his finger and then he's going out to the pointed finger of the provider. And that's one of the easiest ways that we can do that assessment. There's a couple of things that I want to add to that as we're doing it. One, when we're dealing with our population where we're going to experience the most strokes, we're going to have some comprehension issues, both because of maybe A, because they're having a stroke, B, just simply because of age, and sometimes they're so panicked and have so much anxiety that they're going to have trouble comprehending what you're asking them to do. So I physically show them and touch, make them and show them what I actually want. So I grab them, grab their finger and say, go ahead, and I'm going to take out one finger and I'm going to bring it here and I'm going to bring it back to their nose and I'm going to bring it out. One nice tool that I like with this as you're trying to assess their balance and their gait is bringing that finger that they're touching and pointing to out just a little bit further. That forces that person to use a little bit of accessory muscle use. It actually forces them to engage their core. And as they do that, you're using a lot more different type of assessment than you would normally by just moving your finger back and forth. You'll oftentimes find that if they're having strokes that they can easily do this back and forth, but if you add that 1/2 inch to 1 inch further out, reaching out, that all of a sudden they lose that ability. They're no longer able to make that connection to your finger on the outward. So just remember that. Some shaking may be normal. I mean, obviously you have to ask about patient medical history, rule out certain things such as Parkinson's. But even if the patient has Parkinson's, they should be able to complete that task. It's just going to take them longer to do so. And then they should be equal bilaterally on doing those tasks. So they should be, if they can do it on their right side, they should be able to do it on their left. We talk about the lower extremities. You can see in the bottom right-hand picture there where they have the patient take the heel, they start at their knee and work it down to their ankle and then back up to their knee. That's really testing their ability to, in order to have that muscle control and be able to complete a simple task. Again, realize that we as EMS providers are going to have to physically show them what we're asking of them, especially those older folks. What are some important questions that we need to ask anytime we involve the lower extremities? What are some things that might hinder how we would be able to do that assessment? Any thoughts? Think of things like lower extremity problems. Did they have a hip replacement? Did they have a knee replacement? Did they have lower back problems? Did they have fused lumbar or sacral spine, some of those types of surgeries? Ask those questions specifically. Mobility issues, ankle problems, all those things could hinder how we be able to do those tests. So anytime we involve certain extremities or we find a abnormality, I think it's important for us to ask those questions. Do you have knee backer problems? Do you have any problems with your upper extremities that would limit this test? And if the answer is no, then we know that our test is accurate at that point. It's important to revisit each part of the test, not just to skip it because the Cincinnati Pre-Hospital Stroke Scale was positive or negative in one area. And then the last thing with balance I like to talk about is the old phrase that everyone's got one good last walk left in them. We as EMS providers hear that all the time. But the reality is if we can have that patient stand and take a couple of steps to the cot, it's a really, really good assessment. Of course, we want to be there and assist them, but it's a really good assessment of their actual balance and gait. If they can't make that 2 or 3 steps to the cot and turn around without significant problems, then we know there's a gait impairment there. Eyes, sudden double vision or trouble seeing out of one eye or both. So a couple of different things. We want to have them evaluate side-to-side movement. And in order to do that, I always start in the middle. I usually grab their chin and take my finger midline and go one way and then come back and make sure that their eyes can follow, and do the same thing on the other side. And switch hands in doing so. That gives you the full range of motion to make that assessment appropriate. What you're assessing for there is, does that patient have any type of gaze, and do they have the full capability of going all the way one way or the other? We talk about assessing types of gaze and things like that, or we notice that their eyes are fixated to the one side. It's important for us to remember that when they're gazing or they're always fixated to one side or the other, that they're staring at their stroke. So that's usually the side that is going to be affected. So if they're having a gaze that is fixated to the left and they're not able to cross into their right side at all, you can assume that they have a left hemispheric stroke. Another important thing that we don't ever talk about a lot when we talk about eyes is being able to assess all 4 visual quadrants. And so as we do that, we want to make sure that we're out in their periphery, so somewhere out in this area here, and then be able to assess. I always simply like to ask the questions of, can you see which hand is moving, and then move it in the 4 quadrants and have them point. I try to avoid left and rights when I do those types of assessments because it gets confusing. Is it your left? Is it my left? Is it your right? Is it my left? If they're able to point to which side is moving, have them do that. And then make sure you assess all 4 quadrants. What you're looking for there is visual cuts. A lot of times strokes will have where they're able to see midline, but they won't have a good peripheral vision. They'll actually have visual cuts, and that'll affect just certain parts of their eyes and just certain nerves or certain parts to that optic nerve. We talk about face, sudden drooping or numbness on one side of the face or other. Ask the person to smile or show their teeth, and does the patient's face appear to be uneven? If we see facial droop that's only affecting half their face, would that be considered a sign or symptom of stroke, or would that be a stroke mimic? So it's hard to say. I was always err on the side of caution and say stroke, but oftentimes, in order for it to be a stroke, you have to have. Now, Marcy, correct me if I'm wrong. Am I thinking of that correctly? The full face should be involved, or just partial face? You're muted. You're talking, Marcy, but you're muted.
Yes, if it's from the eyes on down, it is a stroke. But if your forehead is also drooping, that is palsy.
Thank you. I wanted to make sure I was telling that correctly before I threw it out there. So, yeah, if that forehead is involved, then it's more likely to be Bell's palsy. That's not to say that you shouldn't already evaluate and activate a stroke code. It's just one of those things that you would maybe note that there was more forehead involvement. But yeah, if your eye's down, that's definite signs of and symptoms of a stroke. Thank you for that clarification, Marcy. I kind of lost my train of thought. We'll talk about arms. Sudden weakness of the arm, or especially on one side of the body or the other, that hemiparesis. Ask the person to close his or her eyes and then raise and extend both arms. Does one drift downward? Some sources recommend palms up, while others recommend palms down. Either option is fine in the pre-hospital setting. Actually, palms down is probably the easier way to look at it. When you get into some, and you talk to some neurologists, they'll often talk about pronator drift, which is that drift from, as they go down, they kind of pronate inwards. That pronator drift really isn't a good indicator in the pre-hospital setting of any neurological impairment. So it's really not part of what we would assess. Either is fine. I just, again, don't make any stroke decisions based on pronator drift in the pre-hospital setting. Have them hold their hands out for at least 5 seconds and be prepared to support an extremity that's weak or affected by that stroke. So obviously we just don't want that arm to plop down or for them to hurt themselves. Make sure you're able to catch that and bring that arm down to their waist or to their legs. Eyes closed is extremely important when we're doing the arm test, and that's simply because we want to make sure, oftentimes if there is impairment, with their eyes closed, they're not going to be able to compensate. But if their eyes are open, they'll try to catch that and compensate. And so that's not a true indicator of stroke or not a stroke at that point in time. Speech, sudden confusion or trouble speaking and understanding. We talk about phrases. Everyone's probably got a different phrase in mind that they like to use. The most common one that we teach is that you can't teach an old dog new tricks. The reality is that phrase has to be at least 7 words or more, and that gives us a good indicator of a lot of different things. What we're looking for in speech is to differentiate between dysarthria and aphasia. When we talk about dysarthria, it's easy because every time I say dysarthria, I slur my speech. And so dysarthria and slurring of the speech, they're able to complete their words, it's just not making much sense, or it's very slurred and garbled. We talk about aphasia. Aphasia is actually how we put together phrases and words, and things don't necessarily make sense. There are 2 different types of aphasia that we should talk about. One is expressive. So when we talk expressive aphasia, these people are able to understand what you're saying to them, but they're not able to express back what they're actually wanting to say. When we talk about receptive aphasia, it's you ask them a question and then they start speaking out random words that have nothing to do with the question that you came back with. I've had both types of aphasia, and in my experience, the more frustrating one is the expressive aphasia. These are the patients that'll often get emotional. They'll have more problems with what's going on simply because they know what's happening to them. The receptive aphasia, they're more confused than they are anything, and what they reply back doesn't make sense, and it's usually a combination of words that just doesn't correlate with what the conversation is going to. So just remember slurred speech, dysarthria. Aphasia is mismatch or miscommunicated words, and then understanding the difference between expressive and receptive aphasia. The last thing we should talk about is time. If a patient is experiencing signs and symptoms of a stroke, it is time to activate the pre-hospital stroke alert. And then BLS team should arrange to intercept with ALS, and it's also a time to establish a last known well. So a couple of things with time I want to emphasize is understand what your transport plan is for these types of patients. The North Dakota Department of Health, the last recertification or relicensure period for ambulance services forced you all to put together transport plans for both cardiac, stroke, and STEMI. And you should have trauma, stroke, and STEMI, and you should have good plans in place for, we're going to use ALS intercept in this particular case, or we're going to use air transport, and which agencies do we call for those additional resources. Ensure that your transport plans are up to date. I mean, we look in certain areas of our state, our air transport options have changed. Like Valley Med Dickinson, in our Dickinson rotor wing base may not be the fastest time anymore because they are not stationed or based in Dickinson any longer. So having that knowledge and making sure that transport plan is up to date may require you to call another type of flight service or another flight service from a different location that may be more appropriate. Or it may now involve you calling an ALS intercept and transporting that patient to the critical access hospital that's stroke ready. All of those things should be evaluated periodically and make sure that everything's up to date. Make sure you understand that transport plan and have the conversation with your medical director and make sure that transport plan is used as it's intended. You know, if you have questions about your transport plans, make sure that you ask them to your medical director and make sure that you understand and you're on the same page before you end up in those types of situations. Last known well, it's the last time that the patient was actually known to be symptom-free. So on the next slide, we talk about why time matters and why things are important. We focus on last known well in a significant amount of cases. And why is it important for us to not use terms like started 20 minutes ago? You know, stroke symptoms started 20 minutes ago. That's what the family tells you when you ask, when was the patient last known to be normal? Why is it important to clarify the actual time that patient's symptoms started? Yeah, and the next provider needs to understand what that means. And so you telling me 20 minutes, even though that the symptoms began at 11:40, you telling me 20 minutes ago, that would mean to me that I'm going to just pass that on to the next provider, right? I do my ALS intercept and I say, yep, symptoms started 20 minutes ago. And then when we get to the hospital, that 20 minutes is the same and it started 20 minutes ago. And we really have no good understanding of what last known well is, right? So one of the things that I like to emphasize is that establishing that time, you know, and then another thing in North Dakota, we need to make sure that we add on to that caveat is Mountain or Central time, especially in the western half of the state. So, you know, symptoms started at 12:03 p.m. Central Standard Time. Those are the things that we would need to make sure we document. Why time this is so important is obviously it affects how we can treat those patients in the facility. It affects how we can administer different types of thrombolytics. And then what is the time frame we have to actually do thrombectomies and interventions, whether it's drug or device at that point in time. We talk about ischemic stroke. Excuse me. The area of the brain tissue that's irreversibly injured is referred to the infarct of the core, and the area of the brain that decreased blood flow that hasn't experienced irreversible damage is called the penumbra. So the penumbra is going to be a term that you're going to be used to and hearing by the end of this lecture, and it's just the area that can be revived or can be reperfused and salvaged. You know, it might not be salvaged fully to its fullest extent immediately, but with some different therapies and some of that this patient can get the function of that brain back. I always compare the penumbra to ischemia versus infarction, right? And so obviously the core is that black area there where that particular area will not come back if we revital or reperfuse it with thrombolytics or the device. We get into that red area, that's going to be severely damaged. We get into that penumbra, that area is as most likely salvageable using thrombolytics or some type of device in order to intervene with that stroke. Every patient, so last known well, we're going to make sure we obtain that on every patient every time. Only use the patient's word from a reliable source. And if you have multiple sources to determine, talk to the RN, the CNA, the therapist, the MD, the family, and just make sure you establish that time before you leave there. Another piece of that is making sure that you have a phone number good for the family member to make sure that they are the hospital and you are able to communicate with them and ask any clarifications or clarifying questions regarding last known well. We don't want to emphasize minutes ago. We don't want to emphasize 15 minutes ago, right before bedtime, because we're not quite sure what that actually means. The more information, the more specific we can get that the better off we'll be in developing our treatment plan. The discovery of symptoms versus last known well. So the last known well versus, and this gets used all the time, and we'll go to example 1 here. EMS was dispatched at 7:45 to a skilled nursing facility for a 76-year-old female with right-sided paralysis. Patient is receiving rehab following an extended stay at a local hospital. They found the patient in the bed this morning and aren't sure what the last known well time, but she wasn't like this yesterday. Upon arrival, the patient is unable to verbalize the crew or any pertinent information. Nursing staff report that they had contacted the night nurse and aide who said the patient had been seen around 11 p.m. when she had called the nurse's station to report a headache. Tylenol was given and no one had checked on her until 7:30 this morning. So what is the patient's last known well in this particular case? So per the medication record, the patient received Tylenol at 3:20 and not at 11. And the patient, depending on how that was documented and if the patient was assessed at that point in time at 3:20, the last known well would be 3:20 in the morning. I would do a little bit of diving. I have a few questions about that transparency there, or that discrepancy, but I think it's important for us to ask the clarifying questions. Was it 11? Was it 3:20? And was an assessment done at 3:20 in the morning, and were they normal at 3:20? Because I think it changes a lot of different things for that patient if it was 11 p.m. versus 3 o'clock in the morning. So I'm glad the rest of you jumped to the 11 p.m. gun with me before we finished reading, but I was on board with you up until we talked about 3:20 in the morning. So just make sure we clarify and confirm. Example 2, EMS dispatched to a private home for complaints of right arm numbness and slurred speech. EMS arrives at 18:10. Patient's daughter reports that this started about 30 minutes ago. EMS completes stroke assessment and calls local ED at 18:15 with a pre-hospital stroke report. Report last known well 30 minutes ago. ETA is 10 minutes. EDRN reports to the ED physician at 18:20. Patient coming to the room 10, last known well 13 minutes ago. Symptoms of slurred speech, right arm numbness. EMS at the hospital at 18:28 report to a nurse, 57-year-old male presented with right arm numbness and slurred speech about 30 minutes ago. Hasn't been taking Coumadin due to a scheduled back surgery tomorrow and a history of atrial fib. What was the last known well? Well, so the answer is quite clearly spelled out there. The last known well was 1740, but we can see some of the problems that we have as that quickly snowballs into a lot of questions for the providers and everyone else, because the reality is that the last known well was 1740, but by the time it was reported at 1828, that could have been 1758 rather than the 1740. It's really unclear. It's important for us to establish that last known well time with the patient and their family and put a time to it on the clock. Report exact time to the physician and nurse at accepting hospital, and make sure we included that in both our verbal and written documentation as we move forward. Each time the patient normalizes, so a patient starts having TPA symptoms, and they resolve on their own after 15 minutes of symptoms, or say prior to our arrival, like Marcy's story was out there. We realize that quickly that patient is normal, they have no symptoms, their stroke scale is negative, their BFAST is negative. That clock starts over. So essentially now we can erase the last time, and if the patient starts having symptoms again, we start the clock again, because the patient self-reperfused, and now we can have a new timeline for TPA. I know I've experienced this several times when I worked down in Standing Rock for a period of time, and I'd have a patient that normalized. I left McLaughlin, South Dakota, and the patient had a stroke-like symptoms when we left. By the time we got to Fort Yates on our way to Bismarck, the patient had normalized. And by the time we got to Cannonball, the patient started having stroke-like symptoms again. So within 50 miles, we had reperfused, And then by the time we got 20 more miles down the road, the patient had started having stroke-like symptoms again. And so it changed my last known well for the patient each and every time that I did that. So make sure you document all of those different things. So get the initial last known well, make sure you have the old last known well or the most recent last known well as well. That's all information that the neurologist is going to want to know. They're going to want to know that they had stroke-like symptoms for 30 minutes, then they normalized, and then 20 minutes later they had a new onset of symptoms as well. But make sure you're very clear in your documentation and your verbal report as you move forward. At that, I'm going to pass it back over to Marcy. She's going to talk about anatomy of the brain and major stroke syndromes.
Okay, so now we're going to look at your brain, and depending on what part of your brain is involved, it will tell you what kind of symptoms you will start to have. So there's three main parts of the brain. There's a cerebellum, which is all that brain matter that you see, and the brain stem, which is the communication between your brain and to the rest of your body. And then the cerebellum is that looks like a walnut on the base of your brain there, and that has to do with muscle coordination. And depending on what part of your brain is affected by has the blood clot or the bleed, will give you a different picture of different symptoms that you will have. So your cerebrum, that's the largest part of your brain, and it's composed of a right and left hemispheres. And this is like your computer center in your brain. It does things like interpret touch. You have your visual fields, your nerves coming from there, your hearing, your speech comes from this part of your brain, your reasoning, your emotions, learning, fine control of movement. Those all come from your cerebrum. So this that is circled with the yellow, if you can see the yellow, that's your cerebrum, the largest part of your brain. So we may be pretty comfortable distinguishing between left and right strokes symptoms. So a left hemisphere stroke symptoms is a sudden loss of ability to produce or understand language. These are your aphasia. This is the people that can't express they can't get the words out, or they can't understand what you're saying. And so I had an example of this. It was this last summer on the ground ambulance, I picked up a patient that he had difficulty speaking, and that's what we got called for. We got there, he had no weakness on either side, but he could not speak. He couldn't get the words out. He wanted to say to his wife, "Do you have the keys?" when he was leaving, and he just could not speak it. He was just frustrated. He could not speak that. Also with this at the left hemisphere is sudden weakness. And so he at this time did not have that weakness, but as we got closer to Bismarck, because we were only 30 miles on the ground ambulance from Bismarck, on the way, he started having some numbness and tingling and not being able to move his right side. So they get sudden weakness, they can have paralysis, or they can just plain have a loss of sensation to the right side of the body. Just this last week ago, I had a patient who came in. He went out, got the mail, came in, wanted to start opening up his mail, and all of a sudden he couldn't feel on his right side. And he had no droop on his right side, but he could still lift his arm, but he felt weak and he had a hard time moving his fingers. He started having numbness and tingling on that right side. And so those are the ones that you start having problems. They can also have visual problems out that right side. Sometimes it can be so bad that they get just a fixed gaze and it looks to the left. And so they're actually looking at the stroke. If they have a fixed gaze and you try to get them to follow your finger to one side or the other, they can't. They may go partially to midline and then it goes back to the left. And that means they're looking at the stroke, and it's just what they call a fixed gaze. And so it can be anything. It can be any of those symptoms, one or all. I've seen them just one at a time that slowly progress to be more, and I've seen them where you have all at the same time. So that's your left hemisphere stroke symptoms. And then your right hemisphere stroke symptoms, now you're starting to get it gets on the other side that is affected. And they may actually get what they call left-sided neglect, that these patients, because of the stroke on the right side, they don't feel on the left side, they don't notice you, they may have fixed vision to the right, that they neglect means they don't even know you're there. They might not be able to hear you on that side, they might not be able to see you on that side, and they just can't do anything with that left side. And so that is neglect. And so what you want to make sure if they're having this is you want to get in their line of vision. If they have a fixed gaze to one side or the other, you want to go where they can see you. And so that they can see what you're doing, because they might not even know and understand who's on that other side. They may have sudden weakness and paralysis on that side, sudden loss of sight on that side, on the left side. And of course, then the deviation of the eyes might be towards the right, which is looking at the stroke on the right side. So it's a left gaze deviation. We have been really good about picking them up. You know, we've all seen them. Those are the people that we've seen. We recognize it as stroke, and we've been really good at calling stroke codes and that. But we get to these other areas where the symptoms are not so obvious to us that they're a stroke. And in the past, we've been missing strokes that would involve the cerebellum and the brainstem. So your cerebellum, this is that part of your brain that controls your coordination, your voluntary movement. Sometimes patients will have difficulty with walking. They feel like they're drunk or they're stumbling. They can't move their legs really well. It also has a role in emotion and cognition. So to refresh our memories, the cerebellum is that walnut area that's circled by yellow. That's where your coordination. So when they say you rang your bell, it's usually from the cerebellum that is been injured. And so you're having problems with coordination. Sometimes they feel like they're drunk, and sometimes, you know, you will have people that the public may not recognize it, the patient may not recognize it, but in the last day or two, they have fallen multiple times, and that leg just does not seem to work really well. And so they can get this, that's when you get those ataxia symptoms. That's the symptoms that Tyler had them reach to their finger and try to reach that finger. And as they're reaching and they're reaching out, your fingers actually are moving, and you can't get it to touch that other finger. And they miss their nose when they come back. They just can't hit that nose. They just actually miss it. Or when you do that that leg test on their lower legs, they can't get their leg to the other leg to be able to do that. Oftentimes they have like sudden dizziness that goes with this, and they're really nauseous that goes along with them. So as you can see, they do not have the right-sided weakness and left-sided weakness. They may just be, you know, feeling like they walk around drunk because they just can't move. That leg's just not moving right, and they're stumbling and can't figure out what is happening. Then you have your brain stem. Now, if you remember right, that brain stem, you get all your major functions that come out of there. It controls your heart rate, it controls your respirations, it controls your blood pressure, it controls everything with the central nervous system in your consciousness. And so these people who get brainstem injuries, they can be really sick. All their motor control comes from it. And these people may be really altered level of consciousness, not responding appropriately. They may not be able to move. They may be weak on both sides. Sometimes they even, because it's so centrally, they might have something on the right side. Your right arm might not be working right, but the rest of their extremities might not. It's just, these people are sick, and sometimes they just can't move any of their extremities, and the only thing they can move is their eyes. These people are often severely dizzy, they may be nauseous, and they get what they call this locked-in syndrome, where they can't move anything but their eyes. These 6 patients are really sick. They need to get help right away. So they may complain of double vision. Both eyes won't move together, and so they get the nystagmus of their eyes, which is the movement of their eyes, and they're dizzy. When you have them track your fingers, both eyes don't move together. They don't have a specific gaze deviation, but may have some visual problems with that. It's sudden nausea, vomiting, vertigo, and tinnitus. The thing about brainstem, a lot of times in the past, the stroke was missed because they have figured they got inner ear problems or something like that was causing it. And so a lot of times can be missed. They have difficulty talking. This is where you're going to see most of the time the dysarthria. This is the slurred speech that you're going to get, and from the brain stem. They may have difficulty swallowing, which is dysphagia, and decreased level of consciousness. And so, like I say, these often can be missed, especially if they're in the mild stages. They say anytime you have dizziness with any kind of other neurological deficits, if you're having problems, have any kind of weakness that goes with it, or you got some visual problems that goes with it, you want to be thinking about the brainstem stroke. Then let's talk about hemorrhagic stroke symptoms. These often come with a sudden severe headache. Like I mentioned earlier, the blood, if it's a subarachnoid hemorrhage, the blood, it gets in contact with the meninges, causing this severe headache. The patients will say, this is the worst headache I've ever had. Even if they had migraines, they may have gotten severe headaches with their migraines. You want to ask them, does this feel like your other migraines, or is it different? They may have intolerance to light, which is similar to what migraines have. They may have neck stiffness and pain. And so they may also, with intracerebral hemorrhage, may have weakness on one side or the other that may go along with it. So you can't tell if this is ischemic stroke or if it's a hemorrhagic stroke. So there's things that can cause what they call stroke mimics. It looks like they're having a stroke, but they're not. And the number one thing we think of often is you're hypoglycemic. They got low blood sugars. And how do we know if that's the cause? Of course, we go and do blood sugar. We want to do their blood sugars and see if it's low. If it's low, then you treat it to bring it up. We don't want to be giving sugar if they don't need it, bring up that blood sugar, because if they are having a stroke, that high sugar can actually make them worse. But you want to fix if it's too low and bring it back, because a lot of times I've seen people that have been confused, combative, altered level of consciousness, have weakness on one side or the other, even with the hypoglycemia. Bell's palsy, that is another time we think, and they get numbness and drooping on one side of the face. Like I mentioned earlier in Tyler's part of the lecture, with the Bell's palsy, the whole side of the face is numb and paralyzed. So you get drooping even of the forehead creases. You can see everything on that side is pulled down. If they're having the stroke, it's usually from the eyes on down and does not include the forehead and the eyebrows. But Bell's palsy, I've seen that quite often, that you can mimic a stroke. It looks like they have that left-sided drooping. And of course, people that have migraines, I have seen people with severe migraines that end up they can't move their one side or the other, so they have all those same kind of symptoms. And like I said before, you want to ask them if they have a history of migraines, is this the same as other migraines that you have? If it's different, it needs to have more investigation. And seizures, if they're post-ictal, a lot of times have some kind of symptoms that also mimic a stroke. And then the tumors and brain metastases. These are the ones that come on slowly. If it's been going on for days, weeks, maybe even months and slowly getting worse, you know what? It's more of a chance that there's some kind of a tumor there than it is a stroke. But with any of these, if you are uncertain, if you think, if we're not certain if this is a stroke, you want to caution on the side that it is a stroke. And when you get them to the emergency department, that's when they're going to rule all these out. And so you always want to call a stroke code. So you want to be, call it and let them decide at the hospital whether or not you are going to, that's actually a stroke or not. Let them rule out everything, because you don't want to delay care, that care that they get at the hospital, just because you think it might not be, you're not certain it's a stroke or not. So we're going to talk about what you need to do as you get on scene. The first thing you want to do when you get on scene is perform the stroke assessment. You want to look at your patient. You know, is their airway open? What's their breathing, circulation? What's their vital signs? You want to get their finger stick, and you want to determine their last known well. You want to obtain any family, some information for the family, like a telephone number if they're not writing with you, that you can know how to get a hold of them for, or the ER can get a hold of them for more questions. You don't want to be spending much time on scene though. You want to determine the appropriate place to go. You know, out in, you know, sometimes you might be in between two hospitals, and it might be, you know, one may be an hour and a half away that has complete stroke capabilities, and you may have another one that's, you know, 40 minutes away that does not have stroke capabilities. Where do you want to take them? You want to make sure you are going to the, you know, to the right place. And sometimes, you know, people, they want to, well, this is the closest hospital, just take me there. But you need to explain to them why they need to try and go to the other facility, rather go to a hospital that has the stroke capabilities, and give them the reasons, the risk versus the benefits of why they should go to the other facility if they don't have the capabilities of taking care of that stroke. So, like I said, limit that time on scene, less than 15 minutes. You know what, when I've always worked in rural ground ambulances, and it's a load and go for me in those, because, you know, if you're got a distance to get to that hospital to get them that care, you know, do your 12 lead on the way. If you're going to do a 12 lead on your, you know, do your blood sugars. And if you've got, you know, if you've got an hour transport time or 40-minute transport time, and you know you got time to work on them, just get them going and do that on the way. Do not be spending a lot of time on the scene. Try to figure out from the family, if the family's not going along, when the last known well is, and, you know, how are you going to get them there? Are you going to need the stair chair to get them out to the ambulance? Because, you know, that's all time consuming. So you just want to try and limit that time on scene. I'm ALS, so I don't start my IVs on scene. I do it in the back of the ambulance on the way in. We don't spend much time on scene. You want to get them to go. And then you want to make sure you're going to the right facility, the most appropriate one. You know, you might need to bypass, like I said earlier, a non-stroke facility to a facility that has the capabilities of taking care of that stroke patient. Here's a map that they have in the state for North Dakota. There's different levels, and Tyler will go into a little bit more information of the different levels of stroke hospitals. But as you can see, there's only one comprehensive stroke hospital in North Dakota, and that's hospitals in Fargo. Both hospitals are comprehensive stroke centers. Some of the hospitals, the rest of them are primary stroke centers, and those primary strokes, some of them are primary plus, where they can do give more medications, have the ICU, they have the vascular interventional radiology, some more things that go with it. And then there's your stroke ready hospitals, which are most of the time your critical access hospitals. And then there's a few hospitals out there that do not have any stroke care, and it could be because they don't have a CT scanner and are not able to do that. So you need to know what type of hospital you have in your area. And like Tyler mentioned before, you're going to have a transport plans. And where are you located, and how are you going to reduce that time to get them to that hospital? And, you know, do you need to be calling strictly ALS, another ALS rig, or do you need to be calling for the helicopter or some other flight program to get them there faster? So now Tyler is going to take over.
Sure. So we're looking at the different types of stroke centers, and obviously Marcy's done a great job of kind of telling you where they're at in the state of North Dakota. But we look at comprehensive stroke center, and we differentiate that between primary stroke centers and primary stroke center plus. And essentially what that means is a comprehensive stroke center has 24-hour endovascular therapy capabilities. And so there are 2 hospitals in Fargo. They have a interventional radiologist on call 24 hours a day, and they're willing to cover that schedule and have enough stroke capacity or enough stroke volume that they meet certain benchmarks for a comprehensive stroke center. We go west in some of our other major tertiary centers. They're either primary stroke centers or they're primary plus stroke centers. The differentiation there is that they have the endovascular therapy capabilities. I take Sanford Bismarck because obviously that's where I'm most familiar, but I look at that facility and we are primary stroke plus, essentially because we don't have the volume to meet that comprehensive stroke center capacity. So, but we have endovascular therapy availability almost 24/7, and we're able to cover and meet the stroke patient needs. Primary stroke center essentially means that we have ICU capabilities and that the patients are able to give all IV alteplase, and they have a neurologist on staff. We get into our acute stroke rotary hospitals, like Marcy said. Those places are able to identify that the patient is not having a hemorrhagic stroke. They're able to take that CT scan, and they are able to administer and start IV alteplase, and then transfer that patient out to the appropriate stroke center. Transport decision, obviously, positive stroke scale equals advanced life support. And I guess I can't emphasize this enough for our BLS providers. And you know, the time and the way things have changed and evolved over the last 5 years with stroke care is so important. But the reality is that the ability to have IV access, the ability to administer certain medications, and provide advanced airway management if it's necessary, and then complete a pre-hospital thrombolytic checklist. These are all things that can be done in the pre-hospital setting by an advanced care provider, and that it may be good to have that advanced care provider in the back of your ambulance with you. So consider ALS intercept versus emergent air transport when it's appropriate. There's lots of different studies on air transport and when it's appropriate, and that's certainly not what we're here to talk about, but make sure you're working with your medical directors to develop those transport plans and making sure that you're using the appropriate resource at the appropriate time. Don't minimize that impact of having a paramedic or that advanced provider in the back of your ambulance with you. En route to the hospital, obviously, we're going to establish a large bore IV access. And so we talk about large bore. We're looking for an 18 gauge or bigger in most cases. A lot of places that are using CT scanners and are using contrast, they're going to want that 18 gauge to be in the AC or higher. So keep that in consideration. When available and when you have the time to do so, a lot of places are going to want you to establish 2 IVs, at least one of those hanging fluids, TKO. Perform a 12-lead EKG and transmit that to the appropriate facility. If they're experiencing a stroke and 75% of those are, 75% 7% of those are going to be ischemic, that means they have some type of clotting disorder or they have a clotting issue, so that we certainly want to rule out any cardiac involvement as well. So obtain that 12 lead EKG, make sure there's no ischemia or infarction going on with the patient's heart as well. Want to put them on a cardiac monitor. Every ambulance service in the state that took grant money from the Helmsley Charitable Trust, it's a good opportunity to place everybody on that cardiac monitor and start saving some of that data and uploading it into your chart through ESO. Assess the medical history, including any prescription medications. Talk about specific blood thinning medications. Are they taking aspirin? Are they on specific blood thinners like Coumadin or warfarin, Xarelto, some of those other types of blood thinning medications? ALS agencies are also going to be able to perform a FAST-ED score. And what that essentially means to you is that we can help dictate the appropriate transport. So, and identify a large vessel occlusion. If we identify that large vessel occlusion, we can help dictate and get that patient to a more appropriate stroke center quicker. And then complete a fibroanalytic checklist or thrombolytic checklist before they arrive at the hospital. A lot of places use their own or some type of generic one, but it's important for us to complete that particular list. Patient handoff, it's very important to establish that last known well, as I talked about before, and make sure you're transferring that information both verbally and in your written documentation. We want to report any history of trauma, presence of headaches over the last 72 hours, any seizure activity, and this could be, generalized tonic-clonic type seizures, and it also could be just staring off into space. All those things we want to assess and dictate and note in our chart. Provide any contact information if witness is able, and that's going to be to ask any clarifying questions. This is extremely useful because how many times do we pick up a patient and I've got to go out and feed the cows and then I'll be right in, and then feeding the cows turns into the water froze over, or the cows got out, or 8 other projects came up while taking care of the cows, and then it's 4 or 5 hours later before that family member gets to the hospital. Getting that information and that contact information of the person who witnessed the stroke is going to be key. Patient handoff. We want to talk about neurological exam findings, level of consciousness, speech, language, visual and field motor strength. Make sure we're reporting our blood glucose value on those patients. I can't emphasize the blood glucose level enough, and it only takes one time to screw that up. And anyone that's been doing this long enough has probably screwed that up. But I can tell a story of, oh, wow, I've got this stroke patient, and I am literally knocking on the door of the hospital, and I realize I forgot to check a blood sugar, and the blood sugar was 22, and I had a stroke team waiting for me. So give dextrose 50% on our way through the door, patient wakes up normal, and now I have a lot of explaining to do of why I didn't check my blood sugar. So use that glucometer, it's there for a reason. Making it a part of your standard assessment and vital signs is a good way to make sure that we don't forget those types of things. Blood pressure is going to be key. Especially when we talk advanced providers, there was a lot of theories out there about treating blood pressure, systemically in the pre-hospital care setting. I know I'm going to talk about it a little bit, and Marcy's going to talk about it more, but we don't want to treat that hypertension in the pre-hospital setting any longer. Result of stroke severity scale, if completed, and making sure that we pass along any of those assessment findings. We talk about the role of EMS. Most importantly for pre-hospital providers, the early EMS notification is going to be key. So this is one piece that we as EMS providers most commonly forget about or don't take responsibility for, in my opinion. But community education, and this creates an opportunity in our communities. And it's really one of the most important responsibilities that we have as pre-hospital care providers, is providing community education that allows us to develop a professional image and helps build that relationship with our community. So making sure that we take the times in our community get-togethers, whether it's over the 4th of July or wherever that town celebration might be, to set up a booth and talk about certain things, whether it's hands-only CPR. In this case, we want to talk about stroke. and talk about signs and symptoms of stroke, because when you pull up a stroke assessment map and the number of patients that die in the state of North Dakota from stroke and stroke-related disease, it's not a pretty color. It's a very dark, dark red, and that's a problem for us. And so that's why we're spending the time and we're making sure we improve the care in our rural communities. You know, share ideas how this can be done. I mean, so if you are in if you're in Mott, North Dakota, maybe something worked really well for you to improve the number of patients that were calling you for stroke-like symptoms. You're going to want to share that with area ambulances around you. And as you come to state and national or state conferences and regional conferences, we encourage you to share those types of things with your other communities and stuff like that around the state, because what worked in Mott may work in Crosby or may work in Mayville, and it's just good information to share all around. And if you're having problems or you notice that trend, ask for suggestions. You know, work with your local EMS association, partner with your community hospitals and your tertiary centers to help provide better education as well. So things that you do: monitor vital signs and check glucose, do administer oxygen. In starting at 2 liters per minute if O2 sats are below 94%. I think we beat this horse dead every time we talk about oxygen over the last 5 or 6 years, but we don't want to provide high flow oxygen to every patient. Obviously, we get into free radicals and its impact on increasing ischemia in both stroke and heart attack. So just titrate that to effect. So if 2 liters isn't quite bringing them up above 90, or they're only sitting at 88, maybe jump that to 4. If you do need to switch them to a mask, start them at 10 liters versus 15 and see if we can titrate that at a lower percentage point between 94 and 99%. We don't want to over-oxygenate our patients any longer. Do not allow aspiration. And so this is one of the hugest things that we can do for our stroke patients, especially if they're having symptoms. Our gut instinct and our initial response is to lay them flat so we can manage them, right? We can take care of them, but that's not the right thing to do any longer. Make sure that that head positioning is 30 degrees or higher, and make sure that we have suction available. If the patient is able to move their arms and they're able to operate the suction themselves with the Yankauer tip, I often give it to them. I've had patients take that yank and stick it in their mouth and suction out secretions so they don't drool all over themselves, and then they pull it back out, and they'll do it with the non-effective side. Again, establish whether they're able to comprehend those instructions, but it's an extremely useful tool, and it allows you to free up your hands to do other things while you're transporting to the hospital. Glucose is going to increase ischemia and infarction, so we want to use glucose sparingly. So unless that patient is less than 60 or they're symptomatic and you really question what their normal glucose level is in those extreme diabetics, we want to avoid giving it. Advanced care providers, I would encourage you to use glucose sparingly. Maybe consider a lower concentration, using like dextrose 10% on your suspected stroke patients rather than D50. And that will often help improve those outcomes for those patients. Do not treat hypertension. Again, we talk about the penumbra and making sure that we perfuse the brain as much as possible. And remember that hypertension is a perfusing mechanism that our body does naturally. We're trying to perfuse as much brain tissue as possible, therefore that we're going to increase that blood pressure in order to do that. And anytime you get into a setting, or even in our facilities, and we're talking about treating hypertension, we have to have trending vital signs. So oftentimes, us being able to trend that in the pre-hospital setting may or may not provide them enough evidence to treat it or not treat it in the facility if it's necessary. So overall, a general rule of thumb is do not treat that hypertension. We do not give aspirin for stroke, and we do not delay our transport. Treatment, we talk about IV alteplase. Given with 0 to 4.5 hours of last known well, it's considered our standard of care for ALS. Limit the size of the infarct by dissolving the clot and restoring blood flow to the ischemic tissue in the brain in hope of improving functional outcome. Obviously, anytime we give a medication, there's risk versus benefits. You know, when we talk about IV alteplase, it's knowing when to give it and how to give it, and then making sure we have the capability of giving it. So making sure we're not taking them to a not acute stroke-ready hospital, making sure that that hospital has alteplase available to them, and they need a CT before giving those medications. We talk about risk versus benefits, and a lot of this is going to be based on the patient, you know, the patient factors, including age, what their comorbidities are, and then what does normal life for them look like? You know, if I'm 55 years old and I drive truck for a living, having visual cuts in my field, visual field cuts, and I will never drive truck again, that's going to be more impactful than I'm 92 years old, living in a nursing home, and you know, I could probably live with a couple visual cuts here and there. I don't really need full eyesight. I mean, it's an evaluation of quality of life that you're willing to have, and developing that based on comorbidities and other risk factors of giving the medication versus not giving the medication. That's something that we're changing statewide and changing all over the nation, is that there are no one set of rules for giving IV alteplase, other than we really don't give it over 4.5 hours, and that's about it. We talk about large vessel occlusions. Marcy talked about the major arteries that supply blood to the brain, and they're outlined here. We talk about the vertebral, the basilar, the carotid terminus, the middle and the anterior cerebral arteries. When we think large vessel occlusion, it is no different than understanding the vessel anatomy of the heart and comparing it to our 12-lead EKG. So all those assessment pieces where Marcy talked about the cerebellar stroke versus and understanding what type of assessment pieces that we're going to see there with the balance problems, the gait problems, and the ataxia. That's similar to saying, yep, they're having a right-sided MI, and what are the signs and symptoms that we would be worried about in that particular case. Your assessment of the 12-lead EKG with practice, just like your assessment of a 12-lead EKG with practice over time and understanding the anatomy of the brain, we're going to be able to help determine some of what large vessel may be occluded versus another. Large vessel occlusions are over 50% of the strokes that we see, and if they aren't treated appropriately, obviously we can have significant deficits and poor outcomes. You know, it's the #1 cause of disability in our nation, so it's pretty impactful. And think about what that causes our healthcare system, or costs our healthcare system overall. We talk about endovascular therapy. It can be done up to 24 hours of the last known well. Oftentimes they're going to want a CT angiogram to reveal the viability of the penumbra. Perfusion scans help determine candidates for intervention versus not. Trial results vary, but most likely around 11 to 20% of stroke patients are eligible for endovascular therapy. So it's worth paying attention to. Mechanical thrombectomy. The goal is to remove the clot and reperfuse the penumbra viable for the brain tissue surrounding the area of ischemia. Just like in the heart, they can actually go in and they can place a stent and keep that open and help prevent future clots or collapses of that vessel. And then make sure they remove. This is images of a CT scan, or excuse me, the interventional radiology scans before and after. You can clearly see where the clot is in this particular case, where the vasculature stops. You can see the guide wire as it comes up into the vessel, and then you can go to the right-sided picture after the clot was removed, and you can see the significant impact of that clot removal and the vasculature that was revealed. That is a lot of area of the brain that would have been impacted and most likely would have resulted in probable disability or death of this patient. Fortunately, the FAST-ED is a large vessel occlusion screening tool that can help identify LVO patients. It's comparably accurate to the NIHSS stroke scale and predicting large vessel occlusions. those of you that work in critical access facilities or any type of facility that uses NIHSS, we all realize that we don't have the capabilities or all the tools to do an NIHSS in the field. And FastED is one of the very few tools that actually corresponds with NIHSS really well. When we talk FastED, again, we talk about facial droop or palsy, arm motor function, speech, time, eye deviation and denial, aphasia, and excuse me, I'd like to buy a vowel, agnosia. The Cincinnati Prehospital Stroke Scale is simple, easily implemented into the prehospital setting. However, it fails to recognize the importance of cortical signs such as aphasia and particularly neglect, which are highly associated with large cortical infarcts. Agnosia is the inability to recognize items or interpret sensation. So again, FastED, there's a training video coming very, very soon. One thing that I would like you to remember, and there is other tools out there, so everything's a YouTube video away. Just make sure you're looking at a reliable source when you're looking for different types of training tool videos. The other piece of that is that FastED, if you're on ESO, it's now part of our ESO documentation. So as you're documenting your stroke, you can use the FastED scale and make sure you put those scores in because it's going to help the state track data. Hemorrhagic treatment, medical intervention, the reversal of blood thinners, reversal of pressure lowering, blood pressure lowering. When we think blood thinner reversal, we think about Kcentra, and I know Marcy's got a great story about how Kcentra was used in a pre-hospital stroke, hemorrhagic stroke patient that was flown from McKenzie County. And the way she tells it is way more interesting, but I'll share a quick synopsis of it. But essentially, they gave Kcentra before they left Watford City, and by the time they got to Bismarck, that patient had noticed a considerable improvement in their condition. Blood pressure lowering when it's appropriate with hemorrhagic stroke, making sure we decrease the chances of a bleed. Surgical interventions include a craniotomy, drilling that hole in the brain or in the skull and releasing that pressure, and clot evacuation. External ventricular drains and aneurysm clipping. And then there's endovascular treatments for hemorrhagic stroke as well, including aneurysm coiling, flow diverter placement, and endovascular abnormality glue and embolization. When we think about blood pressure medications, again, we think somewhere along the lines of labetalol. We want to avoid with minimal cardiac effect other than just lowering that blood pressure. Marcy's going to finish us out here and talk about some data points, and then we'll get you wrapped up for the day.
Okay, since they've been doing some studies, across the country, nationally, there's over 3,000 hospitals that enter data into a registry. And there's 41 hospitals in North Dakota that are a part of it. And what they do is they enter the data and they want to see that there's improvement in what's going on. And so then we can also compare our hospitals to other hospitals that are similar to us and how we're doing our stroke care and trying to improve stroke care. This first slide, it shows how the patients have been arriving at North Dakota Critical Access Hospitals. This is just a cause only. The red line is what EMS is bringing in. The black bar is people arriving on their own. And that tells me that we need to do a better job at educating our people about calling for 911. When I talk to people out in the public, they say, well, it's faster to throw them in the car and take them ourselves, and then they get to the hospital faster. But is it really increasing? Is it really improving how fast you get that care? If you call 911, now they're into the system and the care has been already started, especially if you're way out in, let's say you're an hour from the closest hospital. And so you drive all the way in, they show up at the door at the hospital. Now they got to start their IV. They got to call the CT tech in from home. or wherever they may be at, call the ER doc, and they're like already behind the 8 ball. They're already behind in their care. When you call for 911, the people are getting, you know, even if you have a BLS service, you could call for ALS to get that help. At the very least, you know, you can actually get that last known well. You can notify the hospital that you are coming, what your ETA is. They can call the people in and have them there. If there's a patient already in the CT, getting a CT exam, they can get them out and not put another person in because they know that patient is coming with a stroke and they're going to need that CT. So it just speeds things up if they call 911. And, you know, if you're living right there in town and it's just across the street, yeah, go ahead, take them in. But if you're out in the country and you're really looking at wanting to notify and speeding up the care when you get to the hospital, activating that 911 and getting them into that system of care and getting that along the way and start getting that care and getting them to that hospital in time, and, you know, can actually improve those times. So here's the studies that show that the time at the critical access hospitals, the goal is they want to do the door to CT within 25 minutes. And so 72% in 2018, it went up from 57% to 72%. So we still have some work to do. And now this is 2018, we're 2 years behind. And so, you know, they maybe have been improved now since we've been doing the Mission Lifeline and doing education and things like that. But this is where it's going to increase. If the people come in with pre-hospital, in with call EMS, it's going to decrease that time to get them to the CT and help get them that time there faster. That will help meet this time better because we can notify them, yes, there's a stroke. We've got a stroke code. We're calling the stroke code. And everybody's there, everybody's ready, and now they're to that CT a lot faster. And then there's door to needle time. This is what it takes from the door, time they arrive to the door until they get the TPA, should be 60 minutes in all North Dakota hospital. And you can see we're starting to improve with that as well. So I have one case study I want to review before we finish things out. This is a call that I had as a flight nurse. There was a 54-year-old gentleman out in the rural areas, and I can't remember exactly how far it was, about 11 miles out of town. It was 11 miles from the critical access hospital, and it was like 2.5 hours from Bismarck, where they have the primary stroke center with endovascular capabilities. Ambulance gets called for a gentleman who had fallen, and after they get on scene, the patient has fallen and has right-sided weakness. They do, so if you remember, what it's your two things as initially you want to get right away, most important is your blood sugar and your last known well. They came up with a last known well of 11:30 a.m. And so that was the last known well. They get on there, they assess the patient. The reason the patient fell is because he had weakness. He started out having difficulty speaking, and that was at 11:30, and then shortly thereafter he fell and he couldn't walk, and he had this right-sided weakness. Immediately, well, they had called the critical access hospital and called a stroke alert. And so the first thing that the hospital does at that point is calls in their team to get their CT ready, and then the next thing they called was to call for a flight team to come and meet them. Patient arrives later and at the hospital, and when we get there, the patient he went straight to CT. And so when we arrive, the patient's symptoms were he had right-sided paralysis. He had obvious fixed gaze to the left. He had no idea that I was on his right side. He could not track with his eyes. I had to go on the other side of the bed, and to be able to assess him and let him know, he was unable to speak, nothing. He could not get anything out. He was not able to speak. His blood glucose was still normal. He had no history of trauma, no significant past medical history. This just came on suddenly. When I did the FAST ED score, he got a score of 7. With a score of 7, you got 60 to 85% probability that this is a large vessel occlusion. So when we arrived there, the patient had just returned, just got out of CT. And so as the hospital crew, they gave him the IV TPA, and I started the infusion at that same time. And so that TPA was given 1.5 hours after their last known well. It had an hour and a half time had taken. Upon landing in Bismarck, we landed in Bismarck at the airport. The patient no longer had the fixed gaze. He could now look to his right side. He could start moving the right side, but still had weakness, which was improved. And then he started having garbled speech. And so now he could, before, remember, we could not get anything out. He could not say a word, but now it came out, but nothing made sense as he said it. Patient, then we took him to the hospital CT scan immediately. And then, because I had called it before we left that it was only a 25-minute flight time. And so before we got into the plane, I called the hospital in Bismarck, and I called a stroke alert and said, we'll be there and be ready. And so even if you're taking a patient straight to the hospitals in Bismarck, you want to give them a good leadway, because if you wait until you're 5 or 10 minutes out before you call them, they may have people in the CT already, and they need to still call in their people. They have to call their interventional radiology crew, especially if it's weekends and nights. Or if they are a busy facility, they may have people in their CTs, and so they want to plan for your arrival. So I called, we were 25 minutes before we got there, before we took off in the plane. And since we don't have good communications once we're up in the air, I called them 25 minutes ahead of time, and we just rolled the patient straight into the CT scanner. And then after that, they went to interventional radiology, and they pulled out a large vessel. And the patient went home 3 days later with absolutely no deficits. And so, we recognized this patient had the right-sided weakness, so he was having a left hemisphere stroke with probably large vessel occlusion because of the significance, because he got the score of a FAST ED of 7. So we want to remember, time is brain. Even if that patient is getting TPA, a lot of those patients that have or large vessel occlusions, they need additional care besides a TPA. TPA will start opening it up, but it won't dissolve that whole clot if it's large. And so you still need to think about time and getting them moving on to get that definitive care that there is. And so, you don't, when they call for flight, a lot of times people ask me, one of the questions they call from they ask, well, do you need to have a receiving physician and a receiving hospital before we call flight? And the answer is no. We need it before we leave your facility or what hospital we're going to, but we don't need it when you call us, when you first call us. We get a lot of calls that they say, come and pick them up, unknown destination. And after we get there, that's already planned by the time we get there. So time is brain, and what you can do is the whole system of care. That's how the stroke system of care works. No matter where you are, whether you're in the far corners of North Dakota, and you want to get in that system of care and get those patients to that care as fast as you can. And then remember your BFAST for the ALS people. You can do it further with the FAST ED. Always want to establish your last known well, and make sure you're going to the right facility. Obtain, your glucose level. Prepare to follow your transport plans and get them to the right hospital so they get to that care, and pre-activate the hospital team. At this time, I'm going to open it up for any questions.
Thank you very much, everyone. Have a great day.
Thank you.